Good morning. Thank you for having me among these esteemed colleagues. I need something to step on, though, because I cannot see very well. All right. Thank you very much for the opportunity among these esteemed colleagues. I'll be talking today. I have the distinct pleasure to talk about Roux-en-Y gastric bypass in the United States, if it's a regression or progression. All right. Use the clicker. Okay. Oop, get me out of there. All right. Thank you. All right. I have no financial disclosures to provide. This is my case mix. I will disclose that I love the gastric bypass. I love the sleeve. I love revisions. I love duodenal switches and such. The bands are okay, but otherwise, I do believe that the gastric sleeve, as we talk about, is king and queen, and the princess also. The gastric bypass is now becoming, I guess, as we can talk about, is it becoming a regression or progression in the United States? And clearly, we can see with just this one slide that, unfortunately, the number's coming down. When Dr. Ghanem asked me to give this talk, I was like, well, this is the easiest talk I can give. You know, this is it. This is a slide. We're done. The gastric bypass, you can tell, we're about half of the numbers in the United States, from 36% now to 17%. The band numbers have gone down, the BPD, DS have stayed the same, and revision numbers continue to go up. And so that's an interesting thing. How do we argue that the gastric bypass should be done more in the United States? And so here, worldwide, we also see this. The United States, as you know, does not contribute to this report, so therefore our numbers are low for this. But sleeve overall in the worldwide is also going up too. And so the gastric bypass is here to stay, and I'll argue that. And we know that there's good data, favorable long-term outcomes, remission of comorbidities and weight loss, and it's a great operation for heartburn, especially those conversions for sleeve as well for reflux. And so we look at single center areas here in the United States, there's about 10-year data. We are showing good weight loss, total body weight loss, as well as percent excess BMI loss as well overall. However, and it continues over after 2 years as well for this. Now, is the gastric bypass better than the sleeve? And so we have to look at certain studies, and unfortunately not a lot of randomized controlled trials in the US, as you know. And so we do see that it is better for the diabetes in terms of outcomes, as well as weight loss. And we're seeing the hemoglobin A1C improved after a gastric bypass in the sleeve. And we also see this in, as well in Norway. You know, this is the randomized control trial, and we have to go to our international colleagues to perform these randomized control trials. And we are seeing that, again, gastric bypass is king for diabetes, getting off all medications at 1 year. And we see that compared to the sleeve. But if we start looking at the data, however, there is a large amount of data coming out that is talking more that the sleeve is better than the gastric bypass. This is a recent meta-analysis and of randomized controlled trials, 13 countries looking at the gastric bypass versus sleeve, and there's 33 studies. And they are showing that the gastric bypass shows a bit of a greater loss of BMI, but it's insufficient to say that at 5 years. And unfortunately, there is no difference that they're mentioning that between a gastric bypass and a sleeve for remission of type 2 diabetes and hypertension. And this is a little bit different than what I thought. I thought the gastric bypass was king on this. And unfortunately, we still continue with other studies, randomized controlled trials in Switzerland and Europe, that at 5 years, there's not a significant difference in the percent body mass index between a sleeve and a gastric bypass. And there's different conclusions regarding comorbidity resolution too. So this doesn't help my argument that the gastric bypass is king so far. And also the complication rates, right? We're looking at 30 days from the MBSA-equipped database, and there's a higher risk of death, mortality in the first 30 days and with the gastric bypass as well that we're seeing. And so we can see that there's higher rates of reoperation, leak, mortality, ICU admissions, and such like that. But unfortunately, in this patient population, they're also more sick in the gastric bypass. So looking at elderly patients that we are starting to operate on more, we do see a 3 times increased rate for complications in the gastric bypass population. So this also doesn't help my argument that the gastric bypass is king. So we are going to continue seeing a regression of gastric bypass in the United States. And I want to argue that a little bit of my bias here, that with the gastric bypass going down, we are going to see increasing revision numbers, that the sleeves are also, although we have an increasing number of sleeves, about half of them are going to need a revision down the line, probably 15 years or so in this study in Austria. About half of those patients then had a gastric bypass conversion for weight regain, also for GERD symptoms as well. And so one of the challenges that we have in the United States is training with the gastric bypass. And I can argue that with training fellows, we know that there's an increased risk of complications. If they're involved with an operation especially, there's an increased risk of any complications, serious adverse complications, and surgical complications and takebacks to the OR. But we don't see that as much with the sleeve gastrectomy. So that also argues, hey, we should be doing more sleeves and training our fellows with sleeves. And so, unfortunately, there's a higher rate for complications, as I mentioned. They're associated with the gastric bypass, worse early postoperative outcomes as well. And so they also increase the operative time, as you can imagine. And that fellow participation, there's a decreased amount of complications that you see in the second half of their training period. And so it's important to get them over that hump before they can become proficient in this. This is my bias here, that I feel like that we do too few numbers of gastric bypasses in the US, and so our complications will continue to increase because of lack of exposure too. And so currently our fellowship certificate in the US is you only need to require to do 10 sleeves as well as 50 gastric bypasses or some type of bypass operation and 5 revisional procedures, and only perform about 51% of the case to become a primary surgeon in that. And so there is a learning curve, as we know. To become proficient in the sleeve, you have to only really do about 60 to 100 cases, whereas the gastric bypass, you have to do at least 70 to 150, and that's very low compared to what we require for our fellows here. And proficient meaning knowing how to pivot when there's complications that arise intraoperative, how to manage the patient postoperatively and such. And so that is an important point that we have to continue to work on in the United States. And so this will also lead to gastric bypasses perhaps not being king as much. So robotics hopefully can increase the numbers and the proficiency of this and the comfort level of the technical ease of the gastric bypass. Majority of the cases are still being done in this review, the gastric bypass and laparoscopic, so straight sticks, then robotic. But we see that the robotic numbers continue to increase over time though. And then with this, looking at the outcomes regarding robotic and if it leads to worse outcomes, we have not seen that yet. There's a little bit higher readmission rates from this MBSA-QIP database and a little bit longer operation for the robotics so far. And so we'll see continued data on this being published, I think, in the next 5 years. So overall, I think the gastric bypass remains to be the king and queen. I mean, it is the gold standard still for the metabolic procedure. However, there's a lot of overwhelming data that shows that there's going to be a regression still. And I think surgical training will continue to decline, and that's my own personal opinion. But hopefully with robotic proficiency, it will continue to increase. Thank you.